Hello all. Friends, today we will be discussing on diseases of periradicular tissue. Myself, Dr. Kripa, Senior Lecturer, Department of Conservative Dentistry and Endodontics, Royal Dental College, Chalishiri. So, we should have a clear-cut idea about the various periradicular diseases. As in endo, we will be dealing with these, the treatment, and so on. So, what all are the normal periradicular tissues? We have cementum, periodontal ligament, and the alveolar process. So this is an RC treated tooth, but you can see that periapex is inflamed. So we should know the details of periapex. What is it? What is the importance of it? So first of all, you should know what are the portals of entry of infection. That means if pulp is infected, how it affects the periradicular tissues. There are many portals of communication. These are accessory canals, apical foramina, and dentinal tubules. Slide is very important. We should know the sequelae of periradicular disease. What happens following a pulpal inflammation? This will create an irreversible pulpitis or rather necrosis, which can either be forming a symptomatic apical periodontitis or an asymptomatic apical periodontitis. A symptomatic apical periodontitis is either manifested as cellulitis or as an acute apical abscess. Now, these acute apical abscess can in itself turn chronic later on. Otherwise, these necrosis of the pulp can create an asymptomatic apical periodontitis, which can be manifested in different forms as chronic abscess, phoenix abscess, condensing osteitis, and a radicular cyst. So now, following the treatment of a periradicular disease after an endodontic treatment, what will happen to the periapex? Either it will have a complete healing, or they can heal by forming a scar tissue, or it can remain as a persistent apical periodontitis. So now the clinical classification of periradicular diseases. Symptomatic periradicular disease is subdivided as symptomatic apical periodontitis, which can either occur in a vital tooth or in a non-vital tooth, acute alveolar abscess, an acute exacerbation of existing chronic lesion, which is phoenix abscess. Asymptomatic periradicular disease is subdivided as chronic abscess, chronic apical periodontitis or asymptomatic apical periodontitis, radicular cyst, condensing, osteitis, external root resorption, persistent apical periodontitis, and also diseases of non-endodontic origin. First, we'll discuss about symptomatic apical periodontitis. So, as the name suggests, there will be a painful inflammation of periodontium. The reasons are either trauma or an infection or irritation of root canal. So, this can occur not just in a non-vital pulp, but also in a vital tooth. And the clinical symptom will be a painful response to biting and tenderness to percussion. So how does this occur in a vital tooth? It's blankly due to occlusal trauma. An abnormal occlusal contact or recently placed high point restorations, wedging a foreign object between teeth, like biting a stone or something, traumatic blow to the teeth, all this can create a apical periodontitis in a vital tooth. In a non-vital tooth is usually a sequelae of your pulpal infection, or it can be iatrogenic during the endodontic treatment due to over-instrumentation, irrigating or moving the irrigants more apically, taking medicaments more apically, obturation being overextended, or root perforation. What all are the clinical features? You have pain and tenderness of tooth. Thermal changes does not induce the pain. Usually, slight explosion of tooth from the socket might be there, so that there is a tenderness when you bite due to an inflammatory edema in the PDA. Due to the external pressure, forcing of edema fluid against the already sensitized nerve endings can result in a severe pain. And the radiographic feature will be quite normal, except for a slight widening. So, diagnostic means we have already discussed the clinical symptoms, checking the vitality, and examining the tooth as such. And the differential diagnosis is with an acute alveolar abscess, but usually abscess will be something which like an emergency, and there will be a lot of differences from a chronic lesion, including in bacteriology. So if you take a histology, you can see there is a lot of inflammatory changes there. Vascular dilation, infiltration of acute inflammatory cells, that is polymorphonuclear cells, lot of exudate, and the inflammation will be transient if it is with an acute trauma. Once you remove the irritation, progresses into surrounding bone resorption. Abscess formation occurs if it is associated with some bacterial infection. So the treatment and prognosis is quite good. Treatment is to identify the cause and give the necessary treatment. If it is a high point, you do selective grinding. If it is an infectious pulp, proceed with endodontic treatment. The prognosis is quite favorable. Next is an acute alveolar abscess, an inflammatory reaction to the pulpal infection or necrosis. This is characterized as with rapid onset, a very spontaneous and heightened pain, very tenderness to percussion, pus accumulation, pus formation, and swelling of associated tissue too. Causes are usually due as a result of pulpal infection, which has proceeded to the periapex. Firstly, there will be tenderness, which is relieved by slight pressure on extruded tooth. Later on becomes a severe thrombing pain. Swelling of associated tissue is also seen. In advanced stage, it will be so pronounced that you can't find out from where it has originated. It will spread so much. A tooth will become very painful, a bit mobile too. If left untreated, it will progress to chronic state with the sinus tract. In severe cases, it can turn as osteomyelitis or cellulitis. So the nature of the swelling is to be noted. Whether it is in maxilla or mandible, that is also very much significant. And the tissue at the surface of swelling will always be quite taut, inflamed, and warm. There will be pus formation, and later on can turn into a chronic state. Plus, there will be a lot of systemic symptoms for the patient: fever with chills, malaise. He'll be pale and irritable with lymphadenitis and coated tongue and foul breath. The diagnosis is with clinical examination, the history that the patient gives, testing vitality, and test for mobility and TU, tenderness on percussion. Radiographically, nothing much will be evident, and the differential diagnosis is with a periodontal abscess. So, but for a periodontal abscess, always you can check for pockets. Histopathology, again, acute inflammatory cells and exudates are seen. So this is an emergency situation with established drainage and control of the systemic symptoms. Prognosis is quite favorable. Next is phoenix abscess. So phoenix abscess is something which is an exacerbation of existing asymptomatic lesion. The causes can be anything. like an initiating an endodontic treatment can also be a cause. Symptoms will be just like an acute abscess. There will be tenderness. Tooth will be slightly elevated. Mucosa in the area will be swollen. Diagnosis: it is an exacerbation of a chronic lesion where endodontic treatment has started, or there will be a history of trauma. There will be a discolored tooth which will not respond to vitality, but there has been some reason because of which there is an exacerbation. Radiographically, you can see there are distinct changes in the perioperative. So histopathologically, there are areas of necrosis with the degraded or disintegrated cells and debris. Here, there will be chronic inflammatory cells being evident, and the treatment is again being accessed an emergency, established drainage. Prognosis is okay or good once the symptoms are subsided. Then we have asymptomatic perioradicular disease or chronic apical periodontitis. This is something which is asymptomatic. You can see a definite perioradicular radiolucency and histopathology with dominance of chronic inflammatory cells. So this is a chronic low-grade defensive reaction of alveolar bone to some kind of irritation in the root canal. There is a productive cellular reaction, and the cause is just a pulpal infection proceeded periapically. Symptoms are usually not much, but there is an evident perioradicular radiolucency in the radiograph. Histopathology, where you can see being a chronic lesion, you have granulation tissue, a fibrous capsule outer, central there is loose connective tissue, moderate inflammation by certain chronic cells, form cells, and the presence of osteoclast across the periphery. So this is an HME stain of periapical granuloma. You can see the presence of chronic inflammatory cells. Prognosis is quite good with endodontic treatment. Next is chronic alveolar abscess. This is a long-standing low-grade infection of the perioradicular alveolar bone. Again, patient is symptomless, characterized with the presence of an abscess drained through a sinus tract. The cause, as you all know, will be an extension of pulpal infection, an acute abscess which has turned chronic. The symptoms, there will be a sinus tract, either intraorally or extraorally. And for ease of diagnosis, to find out the tooth which is involved, you can trace your sinus with gutta-percha. Usually a 4% gutta-percha is used. And to spot the origin of infection. In radiographs, you see a diffuse area of bone rarefaction, and the periodontal ligaments will be thickened. Patient gives a history of sudden sharp pain, subsided and has not recurred back, or maybe a history of trauma. Clinical examination, you can see sometimes a open cavity or something which was restored, maybe a crown. May complain of slight pain while masticating. Pulpal test will be non-responsive. So treatment-wise, endodontic treatment, and as soon as the infection subsided, sinus tract and all will go by its own. Prognosis is actually fair because the infection has proceeded so much that it is chronic. So you can see the GP tracing here, gutta-percha used for tracing the sinus tract. Radicular cyst. So cyst is defined as an epithelial line cavity. So you have different types of cyst. Radicular cyst itself can be true cyst or pocket cyst. So it's a slow-growing epithelial sac at the apex of root, lines the pathology cavity in the alveolar bone. And what is filled inside? It's a proteinaceous fluid. This is a periopical cyst. The incidence of cyst is quite high, more in the incisor area of maxilla and also in the mandibular molar areas. So the epithelial rests of molasses are proliferating under the influence of inflammatory cytokines and growth factors. So you have two hypotheses being proposed for a cyst to develop. You have a nutritional deficiency theory and an abscess theory. So actually, nutritional deficiency theory means the cells inside, when they go on proliferating, the vascular supply to these cells will go on reducing because all the blood supply comes from the periphery. As the cells inside goes on proliferating in the center, the amount of nutrition that they get from the periphery will reduce, so that the cells will start to degenerate and will create a cavity inside. That's one of the theory. Second is abscess theory. Abscess theory means there is a lot of degradation and something like an abscess is formed within, which is lined with the inflammatory cells. And you have two types of cyst, periopical focus cyst or base cyst and a true cyst. So base cyst is usually has a communication with the apex. True cyst will be quite independent, separated from the apex. They will not have any communication. The symptoms, there will be pressure from accumulation of cystic fluid, and this will cause some amount of displacement of affected tooth. Roots will be displaced, crowns are out of alignment, teeth might be mobile. If left untreated, it can grow at the expense of your alveolar bone. Radiographically, you can see a definite round or oval shaped periopical rarefaction, and that's easy to identify. See how much it has affected, how the alignment of tooth is also affected. They have drifted the tooth because of pressure. Histopathology, you can see certain chronic cells, a definite epithelial lining, cholesterol crystals will also be evident. Treatment, you go for an endodontic treatment. Sometimes there might be a need of periopical surgery, pisectomy, for a complete resolution. So what is happening as far as mechanism of resolution is concerned for apoptic cyst? Acute inflammatory condition following instrumentation into the cystic cavity. We puncture the wall with instruments and allow drainage. So then that is one method that is being suggested. That is why we initiate an endodontic treatment at the beginning before a surgery, so that there is fibroplasia, collagen will develop inside. If periapical lesions are inflammatory responses to the antigenic content of root canal and the epithelial proliferation in response to the irritation, as soon as you remove the irritation, immune system will repair on its own. That's what the idea behind doing an endodontic treatment for a cyst. Prognosis is based on which tooth is involved, how much bone is remaining or how much is destroyed, and the accessibility for treatment. Another chronic lesion is condensing mastitis. It's a radiopaque lesion, rather diffuse, a bony reaction to a low-grade inflammatory stimulus. This is usually seen at the apex of tooth, in which there has been a long-standing pulpal petosis. So usually symptoms are not there. You diagnose it accidentally when you see it in a radiograph as a localized radiopaque area around that affected tooth. The dense bone with less amount of trabeculation. That's what is the classic feature. And it is the mandibular molars which is commonly involved. So as a treatment wise, you need to remove the irritant and do the endodontic treatment. Histopathology, you can see some bony changes, bony reactions. Next is about external root resorption. It is a lytic process in cementum and dentin of roots of teeth. You have three types based on clinical and histological aspect. External surface resorption, external inflammatory root resorption, external replacement resorption, or rather ankylosis. So here you can see the tooth has undergone a trauma few years back. They have not done a treatment and you can see the surface resorption. The other figure, see, fully eroded tooth. This tooth is ankylosed. Here you can see a cervical resorption. So the causes for external root resorption is either perioradicular inflammation due to trauma, excess orthodontic forces, the presence of cyst or granuloma, some tumors. When the tooth has been re-implanted, you have attempted bleaching, tooth is impacted or some systemic problem. This can occur in an idiopathic way too. Histologically, you see osteoclastic activity is very high. The manifestation can vary. Either there will be small areas of cementum resorption, which will be replaced with connective tissue or cementum itself, or it can be larger areas replaced by bony tissues, osseous, or scooped out areas which are replaced by inflammatory or neoplastic tissue, which will be having a radiolucent appearance. Usually these are asymptomatic. The tooth becomes mobile, then only you come to know that there is resorption. Sometimes it also extends to crown, and that's wing tooth. And ankylosis will create the tooth immobile. It will be infraoccluded and we will have a metallic sound on percussion. Diagnosis, if it is a surface resorption, nothing will be appreciated on the radiograph. If it is inflammatory resorption, you see certain rare irregular areas of root surface or blunting of the apex. Replacement resorption will be replaced with bone with no PDL space, that's ankylosis. Treatment will also vary according to the etiology. If it is some inflammatory reasons, you need to treat it accordingly. And sometimes surgical repair will also be necessary. Prognosis may not be fair always, sometimes it is guarded. So this table from Grossman is very, very important. You can see how the differences are. External resorption is either external surface resorption or inflammatory resorption or replacement resorption, that's ankylosis. Etiology of surface resorption is semi-luxative injuries to the PDA or some excess orthodontic force or any trauma. And usually they are asymptomatic unless for a mobility the tooth is very short. Radiographically, you can see purely nothing. Treatment usually is eliminating the trauma or the pressure, and usually there is no other treatment needed. If it is an inflammatory resorption, it's a long-standing periradicular lesion which has caused it, or some amount of high impact. There is more of mobility, sometimes a sinus pact. Radiographically, you see a lot of changes in the root and alveolar bone. The root canal outline is normal here, but and it is running through the radiolucent. That's how it will be accompanied with the bony resorption. So we go for a pulpectomy. It is a mature tooth. You can place a medicament and then after it. If it is immature, Calcium hydroxide should not be used. You can use something like MT. Then replacement resorption again is as a result of some amount of traumatic intrusion or any reimplantation that you've done following an avulsion. And the tooth will be submerged and infraoccluded, and there is metallic sound on percussion. Here the root is as such replaced with bone, and the treatment is the same endodontic treatment. A differential diagnosis that comes here is with internal resorption. The reasons of internal resorption are also nearly same. A history of trauma or a history of some crown preparation or a pulpotomy. And the inflamed pulp is the tissue which is involved in resorbing here. So initially they will be asymptomatic until the inflammation is progressed and communicating with the external surface. The difference with external root resorption here is the outline of the root canal space will be distorted for internal resorption, and it will usually will not involve the bone. And the treatment for this is also pulpectomy. And then we have the persistent apical periodontitis, post-treatment periodontitis, and endodontically treated teeth. The causes here is some anatomical complexity of your root canal system, the persistence of apical biofilm or an apical scar, actinomycosis, presence of foreign bodies, cholesterol crystals. All this can be a reason for a persistent apical periodontitis. This is an important part. You should know the bacteria involved here. The major one is E. fecalis. Apart from that, you have Candida, gram-positive, certain cocci rods, propionibacteria, and actinides. Then you have certain diseases of non-odontogenic infection like periapical cemental dysplasia, cementoblastoma, odontogenic cyst, fissural cyst, central giant cell granuloma, metastatic malignant tumors, amyloblastoma, presence of an apical scar. In certain cases, we'll feel that they have an endodontic or an odontogenic reason, but later on, when you go for some histology, you can find out that they are something else. And the thing, a differential diagnosis is important because at times we always think about only the pulpal infection and their proceedings. So frankly, we'll jump at doing a root canal treatment without any proper clinical examination or history taking. So what will happen is, knowingly, unknowingly, we are doing a treatment for a tooth. It is perfectly asymptomatic. It is some other thing that is happening there. So prior to jumping up into any treatment, you should have a proper history, a proper clinical examination, vitality and the supporting tests, radiographic examination, if necessary biopsy, to ensure that it is an odontogenic reason. If it is not, go for whatever is the adequate or whatever treatment is to be done for the resolving of the lesion. The pulpal pain associated with the pressure, air pressure variations, microbial colonization in the pulp by blood-borne microorganisms, a tooth asymptomatic at ground level but having pain at high altitude, short, sharp pain lasting for a moment specific to the stimulus and instantly relieved on removal of that stimulus. Patient comes to the dental OP with a sharp momentary pain in a tooth with some restoration. Examine the occlusion. See to it that the high points are removed. Patient in the OP with a chronic with a complaint of radiating pain to ear and TMJ. You see a deep caries. Think about the treatment. On routine examination, a patient has appearance of patient asymptomatic. You see profuse bleeding on probing. You have an abscess. Think about what abscess it will be. During radiographic examination of a lateral incisor, you see a radiolucency, which is an extension of a pulpal infection. Think about. So all these are certain scenarios, okay, different scenarios. Patient will always come to us with pain. It is we who have to decide what is the correct problem of the patient and give the necessary treatment. So all these are certain examples and situations which you will encounter in your clinic too. So to end, that's what my take-home message is. Always students have a doubt. Why do you have to study all these histopathology, differential diagnosis? Why to confuse? So this is what is my message. You should have a clear-cut idea about how to identify, how to differentiate one disease condition from the other.